So it's my pleasure to introduce my associate whose office is just down the hall from me, Carla Nestor. She is the Jean Robillard Professor and Chair of the Division of Pediatric Nephrology at Carver College of Medicine at the University of Iowa. And she has an extensive practice, an international practice in taking care of patients with C3G. But today she's going to talk to us about IgA, membranous, and FSGS. Thank you, Carla.
Yeah, so I'm very glad that he started out by telling you that I practice mostly C3G right now. So you're going to have to be a little careful with your questions of me, or I'm going to take up my 15 minutes of your questioning. So I have lots of disclosures. Also, Richard and I we're not in the clinical trials business until a couple of years ago. Now we are in the clinical trials business. I'm going to be talking about the role of complement in 4 diseases particularly. And, this is not meant to be a pejorative term, but, it's not often that a nephrologist gets the opportunity to be around when there's a new class of drugs that just might work in our disease, right? So we have lots of diseases that actually are looking for a therapy. So it's wonderful that we actually happen to have a new hammer that we might be able to use. So in this set of diseases, you already were told that we're talking about IgA, we're talking about membranous nephropathy, FSGS, and diabetes nephropathy. It is unlikely that complement is going to be a primary driver of disease. I could be proven wrong, like people have said in our next KDIGO. Maybe we'll know more, but right now it's unlikely that they'll be primary drivers. But because there are limited therapeutics that actually work in this set of diseases, or actually is clearly efficacious in this set of diseases, that means that it makes perfect sense to be thinking about the next class of drugs. The morbidity in this set of diseases remains relatively high. And again, some of my presentation is going to be directed at those of you who are not nephrologists, because I want to sort of set the stage for why some of these diseases may be considered for complement inhibition. So starting with IgA nephropathy, the most common primary gene in the world, approximately 40% of IgA nephropathy patients who present at or around the age of 30 will go to end-stage kidney disease over 20 years. So that's not a benign disease like it could be thought about in some patients. Membranous nephropathy, on the other hand, accounts for 20 to 30% of cases of nephrotic syndrome, in particularly white-skinned individuals. 50% of FSGS patients who fail to achieve remission will go to end stage within 5 to 10 years. At least that's what we suspect based on the natural history that we understand. And unfortunately, not quite as bad as C3G, but up to 20 to 25% of those patients will actually go get recurrence of disease in their transplant. So again, not a benign disease. But this one is actually one of my favorites because the number of adults worldwide with diabetes, you heard from Dr. Ramuzzi how many have diabetic nephropathy, but the potential for nephropathy could be there in this 422 million people. So you can see that the potential burden of disease for these currently untreated in a targeted way glomerular diseases could be very significant. Also, I can't help but add, 5 years ago, 6 years ago, and maybe in 2011 when eculizumab first became available to us, or beginning to become available to us, when we were a little bit more scared of complement inhibitors, we are much less scared of complement inhibitors right now, so that we know that they can be used, and perhaps they can be used with a risk-benefit ratio. Even if we're not completely understanding what the target is, maybe they can be used a little bit more easily. And then finally, couldn't help but add, and actually Josh probably set this up for me, I guess, but that it's likely that anti-complement therapy will be equally anti-inflammatory as steroids in a number of the circumstances. And that reminds me, because Matthew and I were talking just before this, the group of patients that I had that were on avacopan were not on steroids prior to going on avacopan. And they did, in fact, have the secondary outcomes that have been discussed, the greater sense of well-being. So this is my devil's advocate piece. It's not necessarily coming off steroids that made these patients have the better secondary outcomes. Anyway, that's very much an aside. So again, for the non-nephrology people in the group, but to also sort of tag onto this, what we know about the pathology for IgA nephropathy is that it's right now it's a 4-hit hypothesis. So first you make the galactose-deficient IgA, then you make the autoantibody to it, then you have immune complexes, and then finally you have deposition of these immune complexes in the mesangium. This is a fairly well-accepted pathway to disease for IgA nephropathy. What I want to challenge you with is should there be a 5th hit in this particular setting, and should that 5th hit, in fact, be the activation of complement? And so in each of these diseases, I'm going to give you some of the evidence. Now, clearly, I'm not going to give you all of it. The evidence is not nearly as good as it may be in C3G or in atypical HUS. So I'm only going to give you some of the evidence, and then the working group will actually evaluate the rest of it based on perhaps some of the review articles that they've read or some of the items that get discussed individually in the group. But I'm going to give you just a few of these. And so I apologize if I've missed anybody in the room who may have published something very pithy that I should have included. So galactose-deficient IgA1 can trigger the alternative pathway, so we have a potential mechanism of disease. C3 mesangial co-deposition with galactose-deficient IgA1 correlates with severity of disease and progression. So we have a reason to think about whether this complement activity actually plays a role in at least the morbidity of the patient disease. And then decreased plasma C3 levels with increased C3 activation products does suggest systemic disease. So again, thinking about a systemic complement inhibition may be a reasonable approach for this disease. And then finally, there's lots of literature on evidence for AP co-deposition, so C3 co-deposition, or lectin pathway activation with mesangial C4, but not C1q deposition. And then, of course, terminal pathway activation with C5b through 9 deposition on the biopsy. So there is actually quite a bit of evidence that complement may be involved, and I have a disclaimer slide, if you will, to sort of think about that. But this is the kind of thing that you will find if you look at review articles. You can see that the lectin alternative and the terminal pathway has been tagged as being potentially involved in IgA in a number of different ways. So this is a pretty large task for the IgA breakout group. Because part of my agenda was to bring to you clinical trials, it turns out that there are clinical trials. This is literally off clinicaltrials.gov, so you can see that there were 9 entries that were listed, and they include a factor B inhibition, factor D inhibition, et cetera, et cetera. You can see all of them listed there, but they're obviously very early on, so you don't get the advantage of me being able to give you some results like the Accolade, for instance, results. So you'll have to wait and hear what's going to happen with these trials. But again, there is enough evidence in the IgA arena to be able to be moving towards trial now. So what are the dilemmas, or what are the problems actually with IgA and the complement system, and what this breakout group is going to have to think about very seriously is this idea of what are the relevant relationships between complement and IgA. So and this is well, I mean, everyone in the room knows that the alternative pathway, for instance, or the is incredibly important, or it's part of your natural, your innate immune system. So deciding how much of this is activation of an innate immune system, sort of a very pervasive system in our body, versus how much is pathologic, is quite the challenge for a lot of the diseases that I'm actually going to be talking about. And we have to be just a little bit wary of the associations that will result. For instance, abnormal biomarker is not proof of causation. So we have to be able to have either the animal models or very clear connections between human findings and human disease, and then what happens if you attempt to treat it, that sort of thing. So it is very much a problem for those of us who want to study IgA and complement inhibition. Also, one of the dilemmas is the goal of therapy. So if you're have targeted therapy, and I'm just going to choose, let's say you want to knock down C5, I'll choose that as an example, versus do you want to actually blunt the effect of C5a? So you have to understand what your target is in order to understand presumably what your outcome is going to be. Because if you don't match your target with your outcome, or are you really searching for anti-inflammation, or are you searching for something that is inhibiting direct cell damage? You have to decide this going in, hopefully to solving your basic science, but certainly before you begin developing a clinical trial. Because if you don't, if you choose the wrong target, or it's going to cause you to choose the wrong outcomes, and then we end up with negative clinical trials, and that frankly doesn't really advantage any of us. How about complement and the membranous nephropathy? So again, a very basic slide to tell you what we know about membranous nephropathy. First of all, we know that there are autoantibodies being formed. This particular cartoon only offers you 2 of them. There are at least 6 others, I believe, and maybe several more that are still in the investigational phase. These autoantibodies bind a antigen in near the podocyte, if you will, so that you get an immune complex formation. And then you get that classic lesion that is seen in membranous nephropathy. And that is the pathology that we understand actually right now for what the underlying mechanism of disease is for membranous nephropathy. Well, what about complement? Well, one of the best pieces perhaps of the role of complement is in the heminephritis rat model, which is a very well accepted model of membranous nephropathy. If you deplete complement, you abolish the proteinuria in that animal model, despite the fact that you do still have those deposits of those immune complexes. So that would suggest that that's Cook's postulates, right? If you can get rid of the complement system and disease gets better, that's a good thing. Complement and membranous autoantibody, which is an IgG4 typically, is required for proteolysis of the nephrin in the model of membranous nephropathy, also very important. And blocking the lectin pathway in this particular circumstance abrogated that result. So again, you're getting an idea that there may be one of the complement pathways involved in the pathology of this disease. Then in each of these cases, I'm going to try to offer you some histology evidence, and this one is the MBL co-staining intensity was an unfavorable predictor for remission of proteinuria with a hazards ratio of 0.4 and renal dysfunction in this particular study. So again, this idea of co-staining of a complement-related protein may be highly suggestive that complement is involved in the pathology of disease. And then finally, I have to bring this one up. Inhibition of C5b through 9 was insufficient in both humans and rats to prevent proteinuria in membranous nephropathy. This actually was a study happening when I was a fellow. I think the reason to bring this one up, though, is that it's not good enough to know that you want complement inhibition. You need to know where in the complement pathway is your target for your particular glomerular disease. Or you, again, risk this idea of an unacceptable trial result. So what am I classing as the dilemmas in membranous nephropathy? And again, the breakout group will actually be able to come up with many more problems, I suspect, and hopefully many more answers. But one of them is that, again, this idea of how much of the co-staining that you see is as a result of activation of the innate immune system for non-pathologic reasons. Again, you have to keep that in the back of your mind. But also this concept, which we're beginning to get a better understanding of, but most membranous nephropathy antibodies are IgG4. We don't classically think of IgG4s as being complement fixing, so that would have been a hole in our understanding, but it turns out that that IgG4 can in fact, or it's beginning to look like IgG4 can activate the lectin pathway. So that is in fact one of the directions that clinical trials are beginning to go, in fact. But doesn't mean that we'll have to know what the class of the membranous autoantibody is before we'll know whether we're blocking appropriately with a complement inhibitor. Again, that's probably too much detail, but it may turn out to be something that we have to understand. And then which aspect of complement is the actual effector? Again, I sort of alluded to this by saying that if you're only going to block the terminal pathway, you may find out that you're not successful. So again, you have to be able to understand what it means to actually block a direct cellular injury complement mechanism versus whether you're blocking an aflatoxin, for instance, just as an example. And this is my opportunity to bring up this idea of, you all will know that the alternative pathway, which is the amplification loop for all three pathways, and that is, in fact, one of the reasons why it becomes such a nice target with some of these agents, right? Because you can be a little sloppier about finding where the actual target is if you block a common pathway, right? That's an oversimplification, but the point is that a reminder that the alternative pathway is the amplification loop for all three. But also, it's not as simple as blocking just the AP if what you really want to do is be blocking the aflatoxins, for instance, because maybe you can do one without having to do the other and get the same clinical effect. So again, the point here is that understanding what your target is will help you understand where to go next. Now let's talk about complement and focal segmental glomerular sclerosis. And I did, by the way, class these diseases in the least amount of evidence as they get farther down in what I'm sharing with you. And in fact, again, for our non-nephrology group, in the normal patient, we have these nice little podocytes, very well formed, that then turn into this cell that's basically been smooshed across the basement membrane or effaced. And in fact, what is not clear, that's definitely, what happens in FSGS, but whether complement could be playing a role in this. In FSGS, for instance, a very clear connection to genetic abnormalities, for instance, which I've not talked at all about in any of the diseases that I'm presenting to you today. But we do understand, obviously, in FSGS that clearly genetic abnormalities can cause this, but can also complement be one of those hits, if you will, that can also exacerbate FSGS or even be a near primary cause for FSGS. So what is the evidence that complement could be playing a role? Well, it depends on the animal model you might choose, but for instance, the AP is active in the adriamycin model of FSGS, for instance. So again, we have some evidence that the AP, or at least one of the complement pathways, can be active and may suffice as a target. This is one of my favorites, is that the decay accelerating factor is downregulated on FSGS podocytes. So you may know DAF is one of the major regulators of the complement system. So you downregulate one of your regulators, and you might have an opportunity for hyperactivation of a complement system. So again, possibly making that a target. And then complement activation fragments, particularly BA, BB, C4A, and C5b through 9, were elevated in the plasma and the urine in patients with FSGS. So again, we have a hint that there is hyperactivity of the complement system. Now we just need to be able to connect that, obviously, to the pathology. And then I'm going to cheat a little bit by hearkening back to something that was actually done in membranous nephropathy manuscript, but complement stimulation of podocytes triggers pyroptosis, I'll say, which is basically a programmed cell death. So complement stimulation of podocytes, and particularly this was C3A and C5A, was responsible for the death of podocytes in culture. So again, we have evidence that podocytes can be damaged by complement. So if you have a podocyte abnormal or a podocyte injured disease, perhaps complement does end up being a target. So what are the dilemmas in FSGS? Well, everyone who is a nephrologist knows this, that we require a better understanding of exactly what is FSGS in those patients. Particularly, of course, we can tie it down fairly well in the genetic abnormalities, but really FSGS is not one disease, and this is a very, we talk a lot about that in C3G, that it's a very heterogeneous disease, but in fact, FSGS is very heterogeneous also. If you take it outside of a clear nephrin mutation sort of patient, then you really have to think again about what exactly is the pathology involved in these FSGS patients. Again, it influences the relative fit of a given animal model, for instance. I don't know if the adriamycin animal model, for instance, represents enough of FSGS to be able to say that complement is active in all FSGS patients, or meaning mice in that particular case, obviously. So because of the heterogeneity, we'll have some difficulty in understanding whether, are all FSGS patients created equally, meaning will they all respond equally to a certain kind of complement inhibition. And because that affects your target, at the end of the day, it affects the therapeutic that you might choose, or particularly it might affect how you recruit patients for a particular clinical trial, for instance. So again, according to my agenda, I'm supposed to tell you about the clinical trials that are coming or that have been done in FSGS, and the short answer is there were none. And this is directly from the clinicaltrials.gov. You all, because we have a number of industry sponsors in the room, they may be able to share with us some of their thoughts of this moving forward. Now, how about complement in diabetic nephropathy? Well, there is decent evidence that islet cell antibodies can fix complement. So those antibodies that are known to be responsible for type 1 diabetes may in fact be able to fix complement. Pattern recognition molecules tend or can bind a glycated protein. So that gives you an opportunity to activate one of the complement pathways by virtue of, if you glycate a complement protein, for instance, do you now have a PRM responsive protein? Hyperglycemia facilitates glycation of complement regulatory proteins. I think, again, that's pretty interesting. If you glycate complement regulatory proteins, this particular manuscript was discussing CD59, for instance, but if you glycate a complement regulator, does that then give you the opportunity to have a dysregulated complement system? Then you now have a reason to consider complement inhibition in this group of patients. And then finally, activation of complement contributes to the pro-inflammatory state and the insulin-resistant state of diabetes. And that's a very broad statement, but it goes with this figure, basically. And again, that breakout group can pull up this particular manuscript, but the bottom line is you can see from this figure that there have been a number of complement proteins been tagged as being in part, associated. Causal is a little too strong, but associated with whether it's diabetic retinopathy, diabetic nephropathy, et cetera, et cetera. So you see that there's lots of opportunity to think that there may be complement activity in this setting. So what are the dilemmas for diabetic nephropathy? Well, I already mentioned it's because we need a better sense of whether these are epiphenomena or whether these are inflammatory phenomena because of the diabetic milieu, I'll say, or whether they are actually causal of one of the pathology pieces that you are actually trying to get rid of. And then there's this sort of question of which one comes first? Do we get the inflammation first and then you get complement activity, or do you get complement activity and that makes the inflammation worse? That sort of thing. And it causes quite a bit of problem in the setting of diabetes, because in fact there are some scenarios where the data is pretty good that complement is actually protective in the setting of diabetes. For instance, C3A appears to be very important in healthy insulin secretion, for instance. So it would not be a good idea if that were an adverse event associated with using complement inhibition. And then factor D is also important for adequate insulin secretion. So right away you could see that perhaps you don't want to block factor D in this setting. And again, that's just obviously speculation. You need actual data to support this a little bit better. But you can see where, again, it makes a difference where you block as to where it might be important for a given disease. And then for our clinical trials in this particular setting, there was one trial completed. I don't know the results of this, but the eculizumab and islet transplantation trial. And so I'm hoping that the breakout group actually will be able to dig into that one a little bit more and see if there are salient points that you can actually take from terminal complement blockade in the setting of transplant of islet cells. So really what I've given you is a very, very quick summary of snippets of information, I'll call it, because there are lots and lots of manuscripts. I should have actually done a PubMed search for you on each one of them and told you how many manuscripts were actually published for each one. There are lots of manuscripts with varying degrees of quality of evidence, frankly. So it will be very important for the breakout groups, and there's two particular great breakout groups involved in this. It will be very important for you all to be able to sort through and figure out which of those data pieces are promising, worth pursuing, or even actually inform next steps already. So I look forward actually to the report out from those particular groups. Thank you.